Welcome to ANA Investigates, a podcast covering the latest in neurology and neuroscience brought to you by the American Neurological Association. I'm your host, Adeline Goss. The coronavirus pandemic has dramatically changed neurologists' lives, both at work and at home. Neurologists are taking on new roles, interfacing with patients in new ways, while our work poses new risks to us and our families. How are clinical neurologists adapting and coping in a time of such change? That's the focus of today's special episode. I'm joined by three of my co-producers on ANA Investigates, Doctors Romer Geocadin, Jim Siegler, and Megan Richie. They are all dialing in from their home offices. Hi, everyone.
Hi, Adeline.
Hello, Adeline.
Hi, Adeline.
So I'll start by asking each of you to introduce yourselves.
I'm Romer Geocadin, and I am a neurointensivist and a professor of neurology at Johns Hopkins.
I'm Jim Siegler. I'm an assistant professor of vascular neurology at Cooper University Hospital, recording from my basement.
And I'm Megan Richie. I'm a neurohospitalist at the University of California, San Francisco, and neurology clerkship director.
So you're all working in different settings right now. Romer, you're in the ICU. Megan and Jim, you're neurohospitalists. And Megan, you're also a neurology clerkship director. Can I ask each of you to share how your day-to-day life has changed in the past month?
Hi, this is Romer again. So my life as a neurointensivist has changed dramatically. Hopkins has converted many of the other ICUs into COVID-capable and COVID-managing units, and one of those has been the neuro ICU. And I was the first attending in our group to go and manage patients in the neuro ICU, and it was a dramatic change from what I'm used to. For COVID-19, the biggest issue really is that it is a massively multi-organ problem. There's a MICU team that is embedded with us. I have a co-attending. But the interesting thing about this is that even the MICU people who are used to ARDS are saying that this is a different kind of ARDS. And so they are also learning as we go along. And one of the things that I think neurointensivists have to contend with is we are always focused on the neurological monitoring and the neurological exam of these patients. And that has shifted dramatically because these patients, the focus is to oxygenate. And in order to achieve adequate oxygenation, patient requires sedation and maybe even paralysis. So therefore, our ability to assess neurological exam in real time is not possible. The other thing also that is very difficult is if we are in the COVID area, we have PAPRs on, so you can see well, but because the air that's blowing over your ear and to your face, you're like in an ocean breeze. That's like this big guzzing sound of wind in your ear. And so your face is dry, your lips are dry, and you cannot hear. But the flip side to that is that people on N95 masks, which are equivalent in terms of protection, and a face shield, their face is practically muzzled in. So you cannot even understand what they're talking about. So it's difficult to round. So what we've done is we've actually devised a way where we write information on the doors, and because all of the unit is practically sealed off from all visitors. So in terms of privacy, all of our communications and plans and goals for the day are written on whiteboards on the doors of each patient so that everybody who comes in, you see exactly what the plan is, what is the goal for the next vent change, and all of those things. And the one thing that is also very glaring when you manage these patients is that there is what we're starting to call a hyperarousal manifestation. We just have a hard time sedating them. Like many of our patients are on 200 mics to even 500 mics drip of fentanyl plus 2 milligrams of Versed, and when you tap them, they're still arousable. I had a patient on 2 milligrams of Versed plus fentanyl, and he's still watching TV and intubated. So there is something that's happening with their brains, and we don't know what to do with them at this point. So we're just sedating them as we need to. So those are some of the key things that has changed in our practice, and I'm actually curious to hear what Megan and Jim have to add from their perspective.
So from my neurohospitalist perspective, I think that the primary change that's come for us has been a shift in the number of patients that we end up seeing from other hospitals and through the transfer center as part of UCSF's deliberate effort to reduce as many elective or non-urgent patient cases and admissions as we can in order to accommodate a potential surge. And as a result, we all are concerned about these patients potentially at other hospitals who need higher level of care, continuous EEG monitoring, EMGs, brain biopsy, who are going without those key diagnostics because of the fact that we have a limited capacity for transfers at this time. Luckily, we have been able at UCSF to start opening up our transfer center more and more over the last week, and we are going to be able to accept these transfers coming in again. But I think that we have definitely seen a reduction in our ordinary transfer volume, which is a major source of the neurology patients that we see on our ward service. From a consult perspective, perhaps the biggest change has been the triage of patients through the emergency room. If someone comes in with a known history of myasthenia gravis and new respiratory complaints, one might expect this to, in an ordinary circumstance, prompt admission to neurology for a myasthenia gravis exacerbation. And yet, in the setting of COVID-19, whether that patient is better served temporarily on our unit dedicated to those patients under investigation for COVID-19 prior to transfer to the neurology service has been a major question.
Jim, you're also a neurohospitalist and working at Cooper University Hospital out there in New Jersey. How are things looking there?
Well, so New Jersey is one of the states that seems to be the hardest hit so far with the coronavirus pandemic. It's the second highest number of patients in the U.S., second to New York. And from my perspective, we've tried to adapt to it by incorporating much more teleneurology and telemedical care. As for me, the volume of telestroke hasn't necessarily changed, but I can tell from the outpatient side that the outpatient providers have almost entirely transitioned to telephone and video-based encounters, which is a challenge, honestly, for elderly patients and patients who have cognitive impairment, populations who have limited resources like the populations that we attend to in Camden. In my own practice and in the hospital side, as a stroke neurologist, we've really embraced this new definition of triage, which patients can be seen, who can be managed over the phone, who can be quickly discharged. If a patient does not need a neurologic exam to answer the consult question, regardless of their COVID status, what we're trying to do is avoid exposing more healthcare personnel to those patients. So we're trying more so now than ever to quickly discharge patients once the initial workup is complete, to arrange outpatient follow-up, additional testing, and so on.
Is there anything you would want to add about the way that visitor policies have impacted patients, specifically with patients who can't communicate and who are now very much alone in the hospital?
Yeah, I mean, it's definitely tough. And, especially in stroke, when the time last known well is a critical component to the care that we're delivering, or what a patient's neurologic baseline is for deciding, are they a good candidate for some sort of aggressive intervention. We often are left with the assumptions, sometimes falsely, that these patients were normal before they came in. And we're trying to avoid the $1 million workup to answer a question that's already been known about why this patient is non-ambulatory at baseline.
On our inpatients, I think that the lack of ability or ease for families and visitors to come to the bedside has been majorly impactful for their care. Just in the last week, we had 2 patients who probably have Creutzfeldt-Jakob disease on our service, and one of them was really quite unable to communicate. And one might think that the physical presence of a family member would be the one thing that could comfort her, and was unfortunately not something that we could offer in abundance. I will say that the telemedicine meetings we have had with families, I have found, have had their actual pluses and minuses for sure. It's hard not to be able to be in the physical presence of these families as they struggle, and to show through your body language as easily your compassion. But I also find that telemedicine meetings have allowed more family members to participate in these meetings than otherwise would have. And I recall one meeting where we had, I think, 9 or 10 different people from an extended family talking to us about the goals and wishes of a patient, where normally that many really couldn't join. And so I do think that there are small silver linings to the remote flexibility that we have been forced into in this time.
Communication to families from and into a COVID unit is extremely challenging. If something emergent is happening, it's really difficult to find them. And it's even harder with end-of-life issues. Actually, there's a policy that we allow for 1 or 2 of the family members to come if it is really dire and the patient is really, for example, like a withdrawal of life support patient. So we try to support it, but it is harder because we do not want them inside a COVID positive unit first and foremost. So that's another different level of challenge.
Megan, you're also a clerkship director. What has that been like in the last couple weeks?
Well, at first, I think there was a lot of uncertainty as a clerkship director in terms of what the future would hold. The beginning proclamation from our School of Medicine was that the students are going to take a break from the clerkships for a week, and we should all make appropriate adaptations. And that quickly turned into 2 weeks. And then finally, we took a little bit more of a longitudinal perspective, understanding that we really needed to be thinking months, if not a year in advance, in order to best protect our students while still advancing their education towards graduation. And it's been really a humbling experience for me because I realized that the last thing the healthcare system needs right now is for a class of interns not to graduate on time. And I do not want to be the clerkship that stands in the way of hundreds of medical students not progressing to their sub-internships and their residencies as needed. And so it's led to a frantic, I hope slightly organized, reorganization of the clerkship to essentially front load those educational experiences that can be done more remotely or through telemedicine for the next several months until we hope things become a little bit safer for the students to re-enter the clinical environment when we have more PPE available, more providers available, and enough patients on the neurologic service for them to examine, hopefully in July.
So clearly for each of you, your day-to-day work life has changed dramatically. And for most healthcare workers in America, this is also the first time that our work puts us at significant risk of personal harm. The virus has now killed many American healthcare workers, and ongoing supply shortages require us to ration and reuse the equipment necessary to protect ourselves. So we risk becoming sick, carrying the virus home to our loved ones, or transmitting it from patient to patient. How has each of you been handling this?
So that is a tough situation that we're in right now, but I think we have to handle it. I think the key point is we do not want to bring this home. When I'm in the hospital, I change into scrubs. And then when I go home, change into clothes that I could put on high heat. All of the ICU practitioners, including nurses, when we're done with our shifts, we actually go to the lockers and take a shower before we leave. And when we get home, so the one thing that we did is we have a designated clean area versus a designated dirty area. So because my wife is also a physician, so we decontaminate. So we take off all of our clothes there in the garage, put them in a designated hamper, and we decontaminate there. We have, Purell gels or whatever it is that we got there. We wipe everything. So and even right now, I don't carry cash anymore. So it's just my phone and a credit card. And we have a transition zone in our kitchen before we enter our kitchen. And the other thing that we've done also when I first came out of the unit, I forced quarantine myself, which is a modified quarantine. So I only sleep in our basement and I'll be there until 14 days that I've left the unit. I don't have any symptoms, but I just want to make sure. And we practice social distancing at home. So We eat together, but I'm on the other side of the table, and my two children and my wife are all the way to the other side. So we just do that just to make sure.
My wife and I also have a similar protocol regarding the garage decontamination procedure. We, completely take our scrubs off and go straight to the shower. The scrubs go into a plastic bag and immediately go into the wash.
I'll just add that I've read an amusing joke online that if you see somebody outside their house undressing or undressed, don't worry, it's just an essential worker coming home for the day.
That is so true.
We've been talking a little bit about the procedures that we are going through at home, or, the transition into home. But I also wonder how each of you is dealing with the emotions behind having a new contagious disease that you could potentially transmit to your loved ones.
The emotions are really intense. When I told my kids that I will be going into a COVID area, they both told me that, Dad, this is what you have been trained to do. And if you have the ability to go save lives, this is the best time to do it.
I want to echo Romer's sentiments too, that this is really a privilege to be able to help these patients and offer our services to them. But, personally, I've never been more scared in my life. And you can probably hear that in my voice, this whole recording. I've been having panic attacks so frequently and been having nightmares about coronavirus exposure and what it kind of means for my family. Like many of us out there, I have a kid, I have a 9-month-old daughter, and my wife and I both are in healthcare. And it's horrifying to know that we come home to her every day and, knowing that she's not the most protected against us. We also have family who are at risk, older parents that want to come visit us. They're local in New York, and it's hard to be able to be there for them. And I know that they want to be there for us. We also have other obligations that are beyond just healthcare. Several of my family members have been let go from work, and so we're doing our best to financially support them. So there's added stress of that. And it's compounded by how some hospital systems are docking pay for healthcare workers, which adds even more stress to the whole situation. We're doing our best. We're panicking the whole time, trying to keep our calm. And yet we have to face these other realities.
So to some extent, my personal reaction to COVID-19 has been one that has only amplified principles that I already held upon becoming a physician. At least for me, medicine is really a vocation. It's a part of who I am. And long ago, I assumed a responsibility towards my patients that I hold in a lot of ways as a sacred thing. And of course, this responsibility also has to be balanced with my other responsibilities as a mother or a partner or a daughter. But I do think that facing COVID-19 has only amplified my sense of commitment to medicine and acceptance that risk is a part of that vocation. And seeing similar attitudes in my colleagues, seeing the sacrifices that they have made, the adjustments that they have made, really shows me that I think many of people are of this mind.
What other signs of hope have each of you found in these dark times?
Hope. We need a lot of that right now, really a lot. I think the one thing that has really surfaced very strongly is that we are all in this together, that we need to take care of these patients, but we need also to take care of each other. And so the teamwork and the camaraderie, even in light of the stress, is just overwhelming. It's even more overwhelming now than it has ever been, in my opinion, which is really a very strong force against this pandemic, where, as we all know, we have no cure.
If I could, I'll paraphrase this cheesy line from Mark Twain. History doesn't tend to repeat itself, but it does rhyme. And my brother told me this the other day, is pretty wise, that this type of event is not the first time that the world has faced such incredible fear and incredible spread of disease. But now more than ever before, I think we are prepared to fight this disease and to overcome it. And I think we just have to be patient, to mobilize resources, continue to maintain social distancing, continue to practice appropriate public health measures, wash your hands, and stay home.
I think a big source of hope for me has been incredible wonder at the ingenuity of humankind. I feel as though people have repurposed their 3D printers or their sewing skills to wonderful new ways of helping out in this pandemic. And I think that in addition to the expected sources of strength and support, I think there will be labs, essential workers who will accomplish things with a creative spirit and thinking outside of the box that will really ease this pandemic in ways that we don't expect.
I just want to add something that's very important, I think, is to quote Charles Darwin, that it is not the smartest or the fastest that will survive, but it is the one who is able to adapt to the situation. And with that, because of ANA as the academics of neurology, the one thing that I have also seen is that there are many, many labs right now that are just really humming at top speed, trying to figure out and answer mechanisms, interventions, as well as best practice. We are learning quickly right now and adapting to the change that is in front of us.
I'm so grateful to all of you for taking the time to speak with us, both about your professional situations and also about how your work influences your personal lives. Thank you for being here today.
Thank you so much for hosting us and for the opportunity to speak, Adeline.
Yes, thanks so much for having us, Adeline. It's a great way to decompress after a long couple of weeks dealing with this.
Thank you so much to everybody and to ANA Investigates, and for allowing us to share a little bit of ourselves to all of you.
That was Romer Geocadin, neurointensivist and professor of neurology at Johns Hopkins University, Jim Siegler, neurohospitalist and assistant professor of neurology at Cooper University, and Megan Richie, neurohospitalist and assistant professor of neurology at the University of California, San Francisco. This was a special episode of ANA Investigates. Thanks to all of you for listening, and we welcome your feedback and your ideas for future episodes. You can go to the Education tab at myana.org to submit those. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association. Thanks for joining us. To learn more about today's program and to access more of the incredible content produced by the ANA, check out myana.org. Adeline Goss is our host. Our producers are Romer Geocadin, Adeline Goss, Michael Halstead, Megan Richie, and Jim Siegler. Our editor is Jen Hurley. If you'd like to learn more about receiving CME credit for listening to ANA Investigates, visit myana.org and navigate to ANA Investigates under the Education tab. For more information not covered in today's program, check out the official summary of this episode, published in one of the ANA's journals, the Annals of Neurology or the Annals of Clinical and Translational Neurology. Copyright, the American Neurological Association.